Welcome to the Deep Dive. Today we are focusing on really a critical intersection of medicine and technology. The use of artificial intelligence in tackling, well, one of the most stubborn and pervasive global health challenges, the rising burden of complex wounds.
It's a huge challenge, and it's multifaceted. We're talking about chronic conditions like, diabetic foot ulcers, pressure injuries, things fueled by an aging population, and, frankly, increasing rates of diabetes and obesity worldwide. So the demand for specialized care is just soaring, yet the systems we have to deliver it are really under immense strain.
And that strain is, well, it's quantifiable, isn't it? The World Health Organization estimates we're heading toward a global shortage of 18 million healthcare professionals by 2030.
18 million?
Yeah, that kind of deficit creates a crisis in just maintaining consistent, high-quality wound care standards. I mean, the sheer volume of patients combined with the complexity of these chronic wounds just feels unsustainable.
It really does. It creates a perfect storm where, quality often suffers simply due to lack of time, lack of specialist expertise, particularly in community settings.
Right.
And it also means that preventable complications, well, they often go unnoticed until they become really serious, sometimes life-threatening.
Okay, let's unpack this then. Our mission today is really to move past the sort of generic hype around AI, and understand exactly how it might offer specific, personalized, maybe even scalable solutions in this really complex field of wound care. We are looking at the enormous promise, definitely. But critically, we also have to examine the crucial barriers to adoption. This deep dive should highlight why the human clinician isn't just necessary for this shift, but actually central to it.
And to guide us, we've synthesized insights from a very significant source, a WUWHS consensus document. Now, this wasn't just a dry technical paper. It was authored by an expert panel, global wound care specialists working directly alongside computer scientists. And their goal was really practical, to simplify this often overwhelming world of AI for busy clinicians, maybe dispel some common myths about the technology, and provide a kind of roadmap for integration.
Right. Let's start by tackling that fear factor, because I think a lot of clinicians hear AI and immediately think of some, futuristic machine taking over. So before we even get into wound images and things like that, we probably need to acknowledge just how common AI already is. The source makes a great point here. AI is already woven into our daily lives.
Absolutely.
We are interacting with AI-enabled systems constantly, often without a second thought.
Exactly. And the goal here is to reduce that AI anxiety by recognizing it's often just a tool, frequently embedded in technology we already use.
Like what? Give us some examples.
Well, if you're getting relevant search results online, or if your digital assistant sets a timer for you, or, your online shopping site suggests the perfect pair of shoes, that's all AI working behind the scenes.
Right.
Even in a healthcare setting, something relatively simple, like an intelligent thermometer adjusting its calibration based on the room temperature. That's using foundational AI principles. It's established tech, not science fiction.
And the term itself is decades old, isn't it? Coined at the famous Dartmouth conference way back in 1956. But for our audience, for specialists listening, what's the best working definition of AI today?
Okay, a good working definition is this. AI is the ability of computer systems to perform tasks that typically require human intelligence. So this includes complex cognitive functions like learning from data, solving problems, abstract reasoning, even understanding natural language. At its core, AI aims to simulate or maybe augment human cognitive functions. It allows us to process information at a scale and speed that's just impossible for any single person.
So if we apply that specifically to chronic wound care, what's its core function there?
Yeah.
How does it actually take, say, a wound photograph and turn that into actionable intelligence?
Well, the process is fundamentally based on data and patterns. AI processes massive, diverse data sets. This might include thousands of wound photos, structured clinical measurements, maybe unstructured clinical notes. It then identifies recurring patterns within that data using mathematical algorithms or sometimes rule sets. And then it uses those discovered patterns to predict future outcomes.
For instance.
For instance, predicting the probability of a wound infection, or maybe estimating the likelihood of healing within the next 6 weeks. It does this based on comparing the current case to thousands or millions of historical cases it's seen. It's essentially a highly scaled-up version of the diagnostic pattern recognition that a human specialist develops over decades of practice.
Right, okay. And here's where it gets really interesting for me, because when most people say AI, they often mean one of its specific subsets, right? We need to clarify the relationship between AI as the umbrella term and the specific technologies it enables. Let's start with machine learning, or ML.
Okay, machine learning. ML is essentially software that learns from experience. So rather than being explicitly programmed with every single rule for every situation, it builds its own predictive model by analyzing vast amounts of data.
So it teaches itself, in a way.
In a way, yes. ML discerns patterns and then uses those patterns to make autonomous decisions or predictions, often with minimal human intervention after the initial model training phase.
And its ability to continuously improve is key here, isn't it?
Yeah.
As it sees more wound data, the model refines itself.
That's a key characteristic of many ML systems, yes. They can adapt. So can I give you a concrete wound care example of how this ML logic might work?
Please do.
Okay. Consider a system using something called logistic regression, which is a common ML technique. It might not be looking at the tissue visually in the way a human does. Instead, it's calculating a healing probability.
Wow.
It takes various inputs that a clinician records, maybe patient age, how long the wound's been present, nutritional status, perhaps the ankle brachial index or ABI, and whether compression therapy was applied. And it weighs those factors mathematically to derive a percentage chance of that wound healing in a given time frame. It's basically performing a highly complex risk stratification almost instantly, something that would take a human clinician quite a while, cross-referencing literature and guidelines.
Okay, that makes sense. Moving up the complexity ladder then, we hit deep learning, or DL. This feels more like that human pattern recognition you mentioned earlier.
It does, yes. Deep learning is a sub-branch of machine learning, but structurally it's quite different. It uses these vast interconnected layers of processes known as neural networks.
Mimicking the brain? Sort of.
Sort of, yes. These layers mimic the structure and connectivity of the human brain's neurons in a simplified way. DL requires exponentially larger data sets and significantly more computing power than simpler ML, but its complexity allows it to excel at highly nuanced tasks, things like visual image recognition, speech analysis, or complex text translation.
And that structural complexity makes it a perfect fit for visual assessment in wound care, where all those tiny details matter immensely.
Precisely. A DL tool, perhaps trained on, say, 1 million wound images, can analyze a new photo. It can identify the exact boundaries, measure the size accurately, and classify different tissue types. For example, distinguishing between healthy, viable granulation tissue and unhealthy necrotic slough.
Wow.
Furthermore, if it's trained on distinct groups of images, it can reliably differentiate between complex conditions that look similar, like telling apart a diabetic foot ulcer from a venous leg ulcer. That's a task that often requires real expert clinical judgment. So DL is really the visual heavy lifter of AI in this context.
Okay, next up we have natural language processing, or NLP. This focuses on pulling insights from, well, the mountains of unstructured text we generate in healthcare.
Yes, NLP is a computational method for machines to understand, interpret, and even generate human language. And this is vital because so much critical information in healthcare exists only in free text.
Like clinical notes.
Exactly. Clinical notes, verbal reports transcribed, EMR entries, consultation summaries, it's all text.
So an NLP-based tool could potentially, mine a patient's entire history, even notes taken by different nurses during dressing changes across multiple clinics over months.
It has the potential, yes.
And it could decipher the healing journey from that text, and maybe flag subtle shifts in wound status, or trigger an alert for potential infection. Things a human reviewer might miss wading through a huge chart.
That's exactly the kind of application. It aims to transform that noise of free text into a clear signal. For instance, it could identify patterns in how pain is described or subtle changes in wound discharge character that, when combined across several entries, strongly suggest an impending complication like infection. It helps extract meaningful, quantifiable patterns from the inherent subjectivity of human language.
Fascinating. And finally, the newest player on the block, the one getting all the headlines, generative AI, or Gen AI.
Right. Gen AI goes beyond just recognizing or interpreting data. It actually creates new content. This could be text, images, even computer code. It does this by analyzing patterns in its massive training data and then synthesizing something novel based on those patterns.
Like ChatGPT.
Exactly, ChatGPT is a prime example. Now, the potential here is huge for applications like, say, drafting personalized patient education materials
Yeah.
or generating mock clinical scenarios for training.
I sense a but.
But it's also where some of the highest risks lie, particularly in terms of generating false but very plausible sounding information. This is what we call hallucinations in AI.
We'll definitely come back to those risks. But before we do, we need to nail down two critical distinctions. These matter hugely for governance and implementation. First, the difference between technology and AI. People often use them interchangeably.
Yes, and we must avoid that confusion. Technology basically describes the physical tools or devices, the smartphone itself, the sensor pad under a patient, the ABPI machine used for measurement. These things collect and feed back data. AI, on the other hand, is the algorithmic system that uses that data to learn, predict, or make a decision. An AI-enabled system uses technology as its input mechanism. But crucially, not all technology contains AI. This distinction matters for things like budgeting, infrastructure planning, and understanding what you're actually buying or implementing.
Got it. The second distinction is maybe even more critical for clinicians navigating the regulatory maze: the difference between assessment and diagnosis.
This is a nuanced but absolutely vital legal and regulatory distinction. An assessment tool measures a variable. For example, it might calculate the area of a wound in square centimeters. That's assessment.
Okay, just measurement.
Just measurement. A diagnosis tool, however, designates a clinical state based on that measurement or other data. For instance, taking that area measurement and other factors, and then designating the wound as, say, severe or a stage 4 pressure injury. That's a diagnostic claim.
And if a tool does both, measures the area and classifies it as stage 4.
If an AI tool combines both functions, calculating the wound area and concluding that it meets the criteria for a specific diagnosis, it requires separate regulatory validation for each function. And the regulatory bar, the level of evidence required for a diagnostic claim, is far, far higher than for a simple assessment claim.
That raises a crucial point, though, doesn't it? Isn't that regulatory hurdle itself going to dramatically slow down the rollout of potentially life-saving tools? How do we balance that safety and regulatory rigor with the urgent need for deployment, especially given that 18 million healthcare professional shortfall we started with?
That's the constant tension, you're right. The consensus document really stresses that understanding this assessment versus diagnosis difference is paramount for safe, responsible implementation. Regulatory bodies like the MHRA in the UK or the FDA in the US are frankly scrambling to create new frameworks specifically for AI because they recognize that traditional medical device regulations are often too slow and rigid for these self-improving algorithms.
So how do we find the balance?
Well, the likely path is phased adoption. Deploying assessment tools, the measurement tools, perhaps more rapidly while putting the diagnostic tools through much more rigorous long-term testing and validation before they're widely used for critical decision-making.
Okay, with those definitions hopefully clear, let's look at AI in action. The promise here isn't just speculative, it's actually happening now. The source mentioned a projected 47.6% compound annual growth rate globally by 2032 for AI in healthcare. That shows huge economic momentum.
Absolutely. And beyond wound care, we're already seeing significant applications. In diagnostics, for instance, computer-aided detection systems are helping to speed up cancer screening for medical images.
Right.
We see it in personalized medicine, analyzing genetic and demographic data to tailor treatments. And even in sophisticated drug discovery, the source cited AI assisting in finding new antibiotics for notoriously difficult drug-resistant microbes like MRSA,
Wow.
which really demonstrates that AI can tackle genuinely complex biological problems with high efficacy.
And the natural transition to wound care seems obvious, partly because AI has already shown massive success in other imaging-based fields like radiology.
Exactly. That created an immediate parallel. Radiology is intensely image-dependent, right? And the source notes that roughly a third of U.S. radiologists are already using AI in some capacity.
A third already? That's significant.
It is. For example, the Yorkshire Imaging Collaborative in the UK uses AI for the initial analysis of hundreds of thousands of X-ray images annually. This dramatically speeds up the workflow for diagnosing conditions like lung cancer. The thinking is, if AI can interpret a complex, often fuzzy chest X-ray, it can certainly learn to interpret the visual characteristics of a wound.
Okay, let's focus then on the first major application area, enhancing wound assessment and diagnosis. What does AI actually add to the clinician's own visual observation process looking at location size, peri-wound skin, tissue type?
Well, primarily, AI provides objectivity and consistency. It can use image augmentation techniques, digitally manipulating lighting, contrast, focus, often revealing subtle tissue changes that might be invisible to the naked eye under normal clinic lighting.
Okay.
And crucially, it interprets the wound status by consistently designating the exact boundaries, calculating area and depth without the variability of using a ruler. And it classifies tissue types, like telling healthy granulation tissue apart from unhealthy slough based on its training.
But is there reliable data supporting this? I mean, does the AI's classification actually match up with what human experts say?
Yes, the source document references numerous studies confirming high inter-rater reliability, which means different users, or the AI and a user, get consistent results.
Okay.
For instance, research using smartphone-obtained wound photos processed by AI showed consistent and reliable results for measuring the wound contour, the area, and classifying the tissue types present across different people taking the photos. Furthermore, specific AI models trained just on diabetic foot ulcers showed high accuracy in distinguishing ulcer photos from non-ulcer photos, and even classifying the type of tissue within the ulcer. This really validates AI as a potentially reliable second opinion or consistency tool.
And that objective assessment then lays the groundwork for what feels like the most transformative application: prediction of healing. This seems to be the big shift, moving wound care from reactive management, change the dressing, see what happens towards proactive intervention based on predictive modeling.
This is truly exciting, yes. We move beyond just tracking what has happened to estimating the future trajectory of the wound.
Any real-world examples?
Well, one successful example cited was an NHS trial of a tool called DeepView. It's designed as a reliable predictor of healing, used initially to estimate burn wound depth, which is notoriously difficult to judge accurately early on. And clinicians involved in the trial praised its portability and the high quality of the imaging it produced, which directly informed critical decisions about whether to pursue surgical intervention or stick with conservative management. Getting that prediction right early makes a huge difference.
And presumably we can apply this predictive power even further upstream towards proactive prevention, trying to stop the wound forming in the first place.
Absolutely. That's the ultimate goal for conditions like pressure ulcers.
Yeah.
The idea is to catch the risk before the injury actually occurs. For example, you could have AI-powered smartphone cameras, maybe using thermal or subepidermal imaging, scanning the skin and underlying tissue of immobilized patients.
What would they be looking for?
They'd be looking for early signs of pressure ulcer hotspots, things like subtle inflammatory markers or localized temperature spikes that indicate tissue stress before the skin breaks down. This allows clinicians to initiate proactive measures, like targeted repositioning, using pressure-relieving surfaces, or applying protective dressings before that tissue breakdown results in a visible, painful, and costly ulcer. That's a massive win for patient quality of life and a major cost saver for the healthcare system.
Another application mentioned is data validation and quality control. AI acting as a gatekeeper, essentially, ensuring the input data is actually good enough to be analyzed.
Yes, the example from Canadian e-consulting is really instructive here. Because of the vast distances, wound specialists there often rely on images sent electronically by staff in remote locations.
Right, telehealth.
Exactly. But to maintain accuracy and also protect the consulting clinician's liability, they implemented an AI tool. This tool automatically analyzes incoming photos and rejects substandard ones.
What counts as substandard?
Things like grainy images, photos taken from really poor angles where you can't see the whole wound, or images that don't show enough of the surrounding peri-wound skin for context.
So the AI acts like a quality filter, protecting the data integrity, but also, crucially, protecting the human practitioner from having to make a critical judgment based on inadequate visual evidence.
That's the critical link, precisely. The AI gatekeeper ensures that the specialist consultant isn't forced or pressured into making a decision based on a blurry or contextless photograph. And the consensus document strongly recommends that this kind of quality control approach should really be adopted globally, and maybe even extended to verify critical metadata automatically, for example, checking if the image shows evidence of compression therapy being applied correctly, and flagging it if it doesn't match the patient notes.
AI is also making inroads into clinical education and training, which seems vital given the global shortage of specialized wound care professionals we talked about.
This is a massive potential aid for onboarding new staff and maintaining competency. AI enables really sophisticated virtual reality or VR scenarios for trainee clinicians.
How does that help?
It offers them realistic exposure to rare or complex wound types that they might otherwise only encounter years into their career, if ever. The source notes that integrating these AI-driven VR scenarios significantly enhances learning and knowledge retention because it provides immediate feedback in a safe environment and allows for repetition until mastery.
I found it fascinating that the source mentioned they're trying to tackle the sensory elements of wound care in these simulations, not just the visual.
Yes, it speaks to the level of detail they're aiming for. Future training efforts are apparently focused on incorporating wound-specific odors into the simulations.
Really? Odors?
Yes, to familiarize clinicians with malodor recognition, which is a critical, though obviously unpleasant, clinical skill related to detecting certain types of infection.
Wow.
Furthermore, when AI is used to help prepare course materials, it can be programmed or constrained to search only pre-specified reliable sources. Things like the latest NICE guidelines or Cochrane systematic reviews, ensuring the scientific accuracy and consistency of all the training content.
And finally, let's talk about reducing clinician burden. This feels like a huge potential win. Generative AI in particular seems perfectly positioned to help with routine documentation tasks and maybe combat some of the burnout associated with endless charting.
Documentation is, well, it's arguably the single largest administrative contributor to clinician burnout across many fields, including wound care. There was a simulated study mentioned that demonstrated an AI tool not only improved the quality of electronic health record documentation, but critically reduced the overall consultation time by approximately 26%.
26% time reduction per consultation.
There.
That's huge. That adds up to hours of tedious charting time given back to actual patient care every week. That's not just about efficiency. That feels like fighting burnout head-on.
It really is a major potential quality of life win for clinicians. And the quality improvements noted were significant too. In a preliminary study looking at AI's ability to prepare discharge summaries, the AI-generated summaries were found to be 100% high quality compared to about 92% generated by junior doctors under time pressure.
Interesting.
So this potential for standardized, high-quality administrative output, freeing clinicians up for direct patient interaction, that's substantial across pretty much all healthcare settings.
Okay, so we've painted a picture of the promise, prediction, precision, productivity. But this brings us squarely to the crucial question. What are the roadblocks? What's stopping this from being everywhere already? The technology itself seems promising, but its foundations. The data ecosystem in wound care you've hinted is often weak. Let's dive into these barriers, starting with the data-related challenges.
Right. The absolute mantra of AI development is garbage in, garbage out. AI algorithms, especially deep learning, require massive repositories of vast, high-quality, and crucially standardized data to train effectively. And in wound care, this data is inherently highly variable.
Why is wound care data specifically so variable? More so than, say, radiology data like X-rays?
Well, because wound care involves so many different dimensions and so many variables that just aren't consistently captured across the board, you're dealing with highly diverse wound types, pressure ulcers, vascular ulcers, traumatic wounds, surgical site infections, each with unique characteristics and healing criteria. Then, data collection happens in all sorts of settings, busy acute hospitals, community clinics, sometimes even the patient's home, often conducted by staff with very different levels of specialized training. And particularly for chronic wounds, which require care over many months, maybe even years, standardized data collection protocols are frequently lacking. This leads to massive inconsistencies and potential biases in the very data we need to train these AI models effectively.
And this often results in missing crucial context, which the source calls missing metadata.
Exactly. Crucial bits of information like the patient's exact age, their underlying gender identity, known comorbidities like diabetes or vascular disease, specific medications that are on this stuff, is often overlooked or recorded inconsistently or not linked properly to the wound image.
And why is that context so vital?
Because it's essential for building a truly holistic and safe AI model. If the model is only trained on wound images, but lacks the clinical context, like knowing the patient's nutritional status is poor or they have peripheral artery disease, it can make wildly inaccurate predictions or recommendations.
The consensus recommendation here was very strong on getting clinicians involved in fixing this, wasn't it?
It was very strong. The document stresses that clinicians must be educated on the absolute importance of data quality and understand what specific components of metadata are needed. We need to standardize how we document comorbidities, interventions, context, to ensure the AI receives robust, reliable information throughout the patient journey.
And alongside data quality, we absolutely cannot overlook data privacy and security, especially, as you said, since wound care often involves highly sensitive patient images.
This is a major, major area of concern. The data required to train these powerful visual AI models often includes intimate wound photographs, images of parts of the body people wouldn't normally show, and when these images are taken on personal smartphones, which is still a common practice in many resource-strapped settings, it raises significant concerns. Concerns about security, about compliance with regulations like GDPR or HIPAA, and fundamentally about maintaining patient dignity and trust. Developing these AI models requires these massive image banks, which means we have to ensure patients fully understand and consent not just to the photo being taken, but to the potential future use of their anonymized image data for training algorithms, potentially across different countries with different privacy laws. There's a real liability risk here if personal devices are used for sensitive image capture without proper encryption, consent, and data governance policies in place.
Okay, let's move to the technical challenges. One issue that seems to generate massive mistrust, especially for those sophisticated deep learning models, is what's known as the black box problem. What is that exactly?
The black box refers to the difficulty, sometimes the impossibility, of understanding the internal mechanism, the specific chain of logic or reasoning by which the AI arrives at its clinical decision or prediction.
Why is it black?
Because unlike traditional software where you can trace the outcome back to specific lines of code dictating a transparent output, a deep learning algorithm might have millions, even billions of parameters interacting in incredibly complex nonlinear ways. We know the input, we see the output, but the process in between can be opaque, even to the developer sometimes.
And why is this lack of a clear rationale such a profound regulatory and ethical challenge?
Because it fundamentally erodes trust and completely complicates accountability. Think about it. If a patient experiences a negative outcome, maybe a delayed diagnosis, because an AI recommended a certain course of action, and the clinician who followed that advice can't articulate why the AI made that specific recommendation. Well, who is accountable?
Good question.
Was it the AI manufacturer? The hospital that implemented the system? The clinician who ultimately acted on the recommendation? This opacity makes validation incredibly difficult. It makes it nearly impossible to identify subtle errors or biases that might have been introduced during the training phase, and it basically forces clinicians to exercise a degree of blind faith, which is completely counter to safe medical practice. It's what really differentiates these advanced AI tools from traditional medical devices, where the function and limitations are fully transparent.
And then there are the hallucinations we touched on earlier, particularly with generative AI.
Yes, and this is a genuine, immediate safety concern. Gen AI models are designed to create content that is statistically probable based on the patterns in their training data, but that doesn't mean it's factually correct or clinically appropriate.
So it can sound right, but be wrong.
Exactly. It can be highly convincing, very fluent, but completely inaccurate or misleading. If Gen AI is used, say, to draft a treatment plan summary, it could potentially create outputs that recommend an inappropriate dressing for a highly exudative wound, or misdiagnose a critical infection based on plausible-sounding but ultimately fabricated text analysis from patient notes.
The source highlighted a statistic here that really must stop us in our tracks. Even outside of medicine, the hallucination rate can be shockingly high.
Yes. It cited a study evaluating the use of Gen AI for high-stakes financial topics, and it found the hallucination rate, the generation of convincing but false information, was as high as 76.7% for certain recent fast-moving topics in some models.
Wow, over 3/4 wrong.
Now, imagine that level of error applied to diagnosing sepsis or recommending whether or not an amputation is needed. It's unconscionable. It just reinforces that Gen AI, at least currently, might be an effective teaching tool or maybe an administrative aid for drafting first drafts, but it is absolutely not ready to be a diagnostic tool or make final treatment recommendations. The clinician's critical filter is utterly indispensable.
Okay. Finally, on the technical side, we face the challenge of integration complexity.
Yeah.
Just the practicalities of getting these tools physically implemented and working within global healthcare systems.
Yes, and the technological landscape out there is, well, it's a genuine mess in many places. Globally, we have what the consensus document aptly calls a mosaic of varying quality and largely incompatible electronic health records, EHRs, and electronic medical records, EMRs. On top of that, many regions, particularly in low and middle income countries, but even in pockets of wealthy nations, have poor underlying IT infrastructure. Trying to integrate a new, sophisticated AI tool with, say, 20 different legacy EHR systems across a region, systems that often can't easily talk to each other. It's enormously complex and very expensive.
Yeah, I can imagine.
This lack of seamless interoperability really hampers cross-system functionality. It prevents the aggregation of the large, unified datasets that the AI desperately needs to learn effectively. Overcoming this requires massive, coordinated investment in infrastructure and standards, which is often limited by already tight healthcare budgets.
That brings us squarely then to the ethical and practical challenges, starting with perhaps the most serious ethical concern: bias in clinical data.
This is critical. If the data used to train the AI is skewed or unrepresentative of the population it will be used on, for example, if it's trained overwhelmingly on images of patients of European descent, then the resulting algorithm will inherently be less accurate and reliable when assessing wounds on patients with darker skin tones.
So the AI actually compounds existing health inequalities.
It risks doing exactly that. We already see studies demonstrating AI's reduced accuracy in analyzing certain dermatological conditions, including wounds, in patients with more pigmented skin. So the AI solution, designed to help, could inadvertently exacerbate the very equity problems it should be trying to solve, simply because the initial data inputs were incomplete or biased.
And beyond racial bias.
Well, the consensus document also points out the risk of commercial bias. If AI development is primarily driven by vendors without strong independent clinical oversight, the tool could potentially be skewed towards recommending specific products or treatments manufactured or sponsored by that developer, which compromises independent clinical judgment.
We also have the understandable issue of clinician trust and acceptance. There's that natural worry about job displacement, but also just trust in the tech itself.
That fear about jobs is real, certainly, and it can lead to resistance or hesitation in adoption. But beyond that, if clinicians don't fully understand how the AI works, or if they suspect that black box output might be inaccurate or commercially biased, they simply won't trust its recommendations, and they shouldn't. So implementation strategies absolutely must be transparent. They need to involve clinicians from the start, emphasize how AI frees up capacity for more complex tasks rather than eliminating roles, and build trust through rigorous validation and clear explanations of the AI's capabilities and limitations.
Regulatory hurdles also present a massive bottleneck worldwide, as you mentioned.
Yes. As we discussed, these AI devices, especially diagnostic ones, require stringent, often entirely new, regulatory testing and approval processes. That takes time. But beyond approving individual devices, the sharing of the necessary data across different organizational silos, like between primary care and hospital specialists, or across different sectors, and especially across different countries, is incredibly complicated by the fragmented global landscape of data protection regulations like GDPR, IPRP, and others.
Right.
This makes it really difficult to pool enough diverse data for robust training and validation while still respecting privacy laws. It's a constant balancing act between necessary governance and the speed needed for innovation.
And finally, there's a slightly paradoxical risk here. The potential for actually increasing the very burden we are trying to reduce the potential for increased burden of care. How does that work?
Well, imagine we successfully implement a sophisticated AI system that constantly monitors patients and flags a critical issue, say. It identifies a definitive red flag for an escalating infection based on subtle image changes.
Okay, that sounds good.
It is good, in theory. But if the underlying human workforce, the nurses, the doctors, is already too strained, too scarce, or the system is too slow for them to respond promptly to that AI-generated alert, then the system ultimately fails the patient.
Ah, I see. The alert is useless if no one can act on it quickly.
Exactly. It could lead to negative patient outcomes because of delayed care. It increases the clinician's potential liability for not acting on the alert, and it simply adds another layer of administrative noise, another flashing light or notification that they must process without having the actual capacity to act on it effectively. So implementation of the AI must be matched by adequate resource allocation and workflow redesign to handle the outputs.
Okay, let's pivot back then to the clinician's role in all this, because we really must dispel that pervasive myth of replacement. The message seems clear. AI is not coming to take jobs. It's coming to augment human capability, maybe liberate clinical time from some of the administrative monotony.
That is absolutely the unequivocal truth hammered home in the consensus document. AI supplements and augments existing clinical experience and judgment. The human clinician remains utterly indispensable.
Why? What can the human do that the AI can't?
Well, the clinician is the only party that can provide the necessary practical context. They gauge the clinical utility of the AI's output, not just its statistical accuracy. They identify the subtle, often non-quantifiable barriers to healing, things like patient adherence issues, psychological factors, social determinants of health that fundamentally determine real-world healing outcomes. Without that human context, the AI system is just performing a calculation in a vacuum. It lacks real-world wisdom.
And the source outlines a clear development cycle where the clinician isn't just an end user, but involved at every single stage.
Exactly. This partnership is presented as non-negotiable for success. Clinicians are crucial right from step one,
Yep.
defining the actual clinical problem the AI needs to solve and setting the necessary parameters for the tool. They must then be involved in validating the outcomes, assessing not only if the AI is statistically accurate, but if it provides genuinely useful information that changes management for the better. They ensure the tool correctly applies human context. And finally, during implementation and ongoing use, clinicians provide continuous feedback on real-world barriers, monitor performance for unexpected issues, and ensure patient safety. A successful AI tool in healthcare has to be co-developed, not simply delivered off the shelf.
This leads us directly to highlighting the uniquely human elements, the qualities that AI simply cannot replicate, no matter how sophisticated it gets. The first one mentioned is professional judgment.
Yes. Even with a highly accurate AI providing recommendations, clinicians must never operate on autopilot. They must always apply their own professional judgment and critical thinking skills, especially given the known risks we've discussed, like the black box problem and the potential for Gen AI hallucinations.
So the AI is an input, not the decision maker.
Precisely. The AI provides a recommendation, perhaps a probability score, or an highlighted area of concern. But the clinician must synthesize that information with the individual patient's full context, their history, their preferences, their current condition, to make the final, nuanced clinical decision.
The second uniquely human element is compassion and care. The idea being, if AI does successfully save clinicians time on admin, that time must be reinvested back into the human side of care delivery.
It absolutely must. Empathic and compassionate care isn't just nice to have, it's a fundamental human requirement in healing. It is proven to significantly improve patient outcomes, enhance adherence to complex treatment plans, particularly for chronic conditions, and reduce the significant psychological stress often associated with long-term illness and wounds.
And AI can't provide that.
AI cannot provide genuine empathy or comfort. It can only, hopefully, free up the clinician's time to deliver it. By doing so, it can help improve patient engagement, build trust, and ultimately contribute to better healing rates. That time saved has to be repurposed for human connection.
And the third key human element is patient communication. While technology like chatbots or translators can certainly assist, the core task of building trust and understanding individual patient barriers remains firmly with the clinician.
Yes. A human professional is required to sit down with the patient, build that rapport, build that trust, and really dig into identifying the complex, often interconnected barriers that are preventing healing. These could be issues related to nutrition, mobility challenges, social isolation, financial constraints, or poorly managed pain.
Things an algorithm won't easily pick up.
Exactly. AI tools can assist, for example, by providing accurate real-time translation or perhaps filtering routine patient questions via a chatbot to free up clinician time. But the expertise in interpreting those subtle cues, applying those insights sensitively, and motivating the patient to engage with their care plan, that remains uniquely human.
Okay. Given this central role, it follows that the clinician community needs specialized, tailored AI tools, not just generic off-the-shelf solutions. The document really stresses the need for etiology-specific systems, right? Tools designed for specific types of wounds.
Yes, very much so. We need sophisticated diagnosis and prediction tools that are customized for the nuances of specific wound types. These tools must be capable of accurately identifying the precise etiology, the underlying cause, mapping different tissue types within the wound bed, assessing infection status reliably, and predicting the likely healing trajectory with high confidence for that specific wound type.
Let's drill down into the specific requirements for a couple of complex examples, starting with diabetic foot ulcers or DFUs. What does an AI tool need to do there?
Okay, DFUs are incredibly complex because you have that interplay of neuropathy, ischemia, and high infection risk. So, an effective AI tool for DFUs must be able to analyze standard wound images, perhaps augment them using different light spectra to visualize microcirculation status or bacterial load. It needs to classify the ulcer severity accurately using standardized systems.
And differentiate tissues.
Crucially, yes. It must reliably differentiate between healthy granulation, unhealthy slough, signs of ischemia or necrosis, and active infection signs like surrounding cellulitis. The ideal AI would create a holistic picture by combining that imaging data with risk factors pulled automatically from the EMR, like HbA1c levels, vascular status, and then predict the likelihood of healing versus the risk of deterioration or amputation to guide really immediate, targeted intervention.
Okay. And what about pressure ulcers, or PUs, where prevention and constant monitoring are so critical?
Right. For pressure ulcers, the AI needs to be highly integrated with the electronic patient records, using ML or DL algorithms to continuously scan patient data for known risk factors, things like immobility scores from nursing assessments, nutritional status markers, existing medical devices that might cause pressure.
So risk stratification.
Yes, dynamic risk stratification. It must also assist in accurate staging and categorization if an ulcer does develop. And ideally, it would utilize data from advanced sensors, maybe sensors integrated into specialized mattresses, or even negative pressure wound therapy devices to identify subtle pre-ulcer indicators like sustained pressure peaks or localized inflammatory markers in the tissue.
And potentially even manage risk.
Potentially, yes.
Huh.
It could even help manage risk by, for example, coordinating with robotics for automated patient repositioning schedules based on real-time pressure mapping. It essentially aims to shift some of that burden of constant vigilance and repetitive tasks away from the human nursing staff, allowing them to focus on more complex care leads.
Beyond diagnosis and prediction for specific wounds, the source also identifies some crucial clinical care-related unmet needs that AI could potentially solve. These seem to relate more to systemic failures or gaps in current care delivery, things detailed in their Table 2.
That's right. There are four primary system-level needs that the expert panel highlighted. First, they called for an MDT interface, a multidisciplinary team interface.
What would that do?
This would be a system designed to seamlessly connect different care settings, the community nurse, the acute hospital ward, the specialized wound clinic, allowing all the relevant care providers access to the same real-time wound data and healing progress information.
Okay, breaking down silos.
Exactly. And crucially, this interface would automatically trigger specialist referrals or alerts at the precise moment a wound deviates significantly from its predicted healing trajectory, ensuring timely intervention.
That addresses the current fragmentation of care. What's the second major need identified?
Second, they proposed a specialized wound care provision system. You can think of this as a kind of virtual triage nurse for wounds, perhaps similar in concept to a non-emergency health advice line like NHS 111 in the UK.
How would that work?
It would be designed specifically to direct patients with non-emergency wound issues, maybe a query about a leaking dressing, or concerns about localized redness to the right level of care, potentially away from overcrowded accident and emergency departments. This saves emergency resources for truly critical issues and gets the patient appropriate advice faster.
Makes sense. And the third unmet need focuses on the economic aspect, cost effectiveness.
Yes, and this is critical for sustainable healthcare systems and for justifying investment in better wound care. We need AI tools that include a function to assess the cost-effectiveness of various healing strategies in specific contexts.
How would AI do that?
It could analyze local formulary costs, staffing resource constraints, and link them to actual patient healing outcome data captured by the system. This would help build a robust, data-driven case for using advanced therapies when appropriate, ensuring that treatment recommendations are not only clinically sound, but also realistic, affordable, and justifiable based on genuine value-for-money evidence, rather than just historical practice or vendor claims.
Okay. And the fourth point really underscores that massive systemic problem we touched on earlier, the desperate need for effective data sharing platforms.
This is perhaps the foundational requirement on which all the other potential successes rest. As we discussed, the current landscape is often crippled by a lack of interoperability. Different wound care apps developed by different companies, various localized ERM systems, they often can't effectively or easily communicate with each other.
Which means data gets locked in silos.
Exactly. So the call is for a unified AI platform, or at least common standards, capable of securely connecting this variety of global systems.
And the current lack of this interoperability causes significant waste of precious clinician time, doesn't it? You hinted at this earlier.
Tremendous waste, yes. A clinician might use a fantastic specialized wound care app on a tablet for guided assessment, getting great data, but then they are often still required to manually type or dictate the exact same data points into their separate local EMR system for the official record.
Duplication of effort.
Complete duplication. It leads to frustration, increases the risk of transcription errors, consumes valuable time, and results in suboptimal outcomes because the data isn't flowing efficiently. Achieving genuine interoperability would not only save clinician time, but also allow decision makers from local service managers right up to national health policy planners to access aggregated, anonymized analytics on resource utilization, treatment effectiveness, and healing rates across populations, driving real system improvement.
This sounds less like a simple tech integration and more like a necessary fundamental revolution in the whole data ecosystem of wound care.
I think it is. It's a revolution aimed at achieving true system-wide improvement and enabling genuine wound care specialization. The ultimate objective is to deploy AI effectively to handle the more routine assessment, documentation, and predictive care decisions. This frees up invaluable time for experienced clinicians to upskill, focus their expertise on the most complex and challenging cases, and help address that chronic global shortage of specialized wound care professionals. #outro.
So to summarize our deep dive today, AI is clearly not some hypothetical magic bullet for wound care, but it's emerging as a powerful accelerant. It's enabling a fundamental shift in how we approach wounds. We're moving, or trying to move, from the current reactive, often crisis management model towards a much more proactive, predictive, and ideally truly personalized treatment framework.
Absolutely. However, the success and effectiveness of this entire transition hinges entirely on two absolutely critical pillars. First, the establishment of vast repositories of high-quality, unbiased, standardized, and ethically sourced data. And second, the deep incorporation of clinical expertise, wisdom, and judgment at every single stage of the AI's development, validation, and implementation cycle. The experience of the wound care clinician remains the ultimate non-negotiable filter.
Right. So the crux of the matter seems to be that as these AI technologies continue to advance at lightning speed, we must ensure that our regulatory frameworks, our clinical guidelines, and our ethical considerations evolve just as quickly. We need to constantly find that balance between encouraging innovation and upholding the core principles of patient safety, health equity, and clear accountability.
And the source material leaves us with a very specific suggestion, almost a challenge. It suggests a need for a step-up AI tool specifically for clinician education. One trained on real-world data designed to gradually enhance decision-making complexity for trainees or those new to wound care. But this raises a highly provocative final question for you, our listeners, to consider. How do we ensure that even as AI gets better and better at handling the routine assessments, the measurements, the predictions, how do we simultaneously develop robust knowledge retention strategies so that fundamental human clinical skills, that intuition, that nuanced understanding of subtle tissue changes, the ability to connect disparate symptoms back to the underlying cause, how do we ensure those skills don't erode over time simply because the machine is doing more of the apparent heavy lifting?
A profound challenge indeed, navigating our technological future in healthcare. Thank you for joining us on The Deep Dive.